Good morning, everyone. Thanks for joining me this morning. I'm Jason Andrade, and I work at the Mahoney Group. We've been in the insurance and benefits business for more than 100 years, and the last time I looked, ranked somewhere among the top 100 brokerages in the US. My focus is on helping our clients build the confidence they need to face whatever lies ahead. That's not always easy, but we're delivering custom-tailored solutions to bring value and truly protect those we serve. This morning, we'll be hearing from three experts in the fiduciary duty, benefits, and legal fields. They'll be offering you some highlights and definitely some details you need to know about the Consolidated Appropriations Act, which I think people are beginning to understand is definitely a game changer. To start us off this morning, you'll hear from Jamie Greenleaf, the co-founder of One Vision. Jamie has been focused on helping employers understand their fiduciary obligations her entire career. She's worked at UBS and Prudential and launched into consultancy in the mid-1990s. And in 2020, after the CAA was signed into law, Jamie co-founded One Vision. Joining Jamie this morning as a presenter is Hugh O'Toole, the CEO of Renovu. His company is dedicated to eliminating waste from healthcare costs and improving the health and financial security of employees and their families. Hugh serves on the board of the Center for Board Certified Fiduciaries, an entity whose purpose is to provide fiduciaries with a better understanding of fiduciary standards. Last but not least, we'll also be hearing from Karen Handorf. Karen is a member of Berger Montague's Employee Benefits and ERISA Practice Group. She works with plan sponsors, plan participants, and beneficiaries in the employee benefit and ERISA cases in the federal courts and on appeal. Her experience includes 25 years at the U.S. Department of Labor. And now, without further ado, Jamie, please take it away.
Good morning, everyone, or afternoon. I guess it's still morning. Good morning. I think we have a slide presentation to pull up. Great. So if we flip to that next slide, really the intent here is to help you as employers kind of understand the changes in the regulatory environment around your healthcare plans. In doing so, our job really is to help you minimize the risks. And we know through prior experience that by doing the right thing, you're going to improve your plan for your employees. So let's take a kind of a step backwards. And why don't we flip to the next slide? Growing up in the retirement industry, our mission was always to help employees retire with dignity. So we really looked at outcomes. But prior to the 408(b)(2) regs coming to fruition, the industry was kind of riddled with conflict. And so what happened is that employers offered a lot of funds and it was choice overload. And the individuals that were doing the education were actually commissioned specialists that sold ancillary products to the participants when they were talking to them about their retirement plan. The average costs were higher. There were some termination fees, and the fees were eating up the returns. And we had low utilization of the retirement program, which ultimately increased companies' liabilities. And we saw, unfortunately, casualties of lawsuits. But today, if we flip to the next slide, the industry has added transparency through the 408(b)(2) regs in the retirement space. And we've moved from an industry that just used to have a salesperson, a commissioned salesperson as a broker, moved to a consultant, and then moved to a fiduciary. In doing so, employers became fiduciaries on their plan, establishing a prudent process, limiting the funds that were available to their employees so that there were better outcomes. In doing so, they reduced costs, in heightened transparency around fees and services, and the utilization of the plans were much higher, better plan design, and optimized company contributions. And the average account balance today of most employees participating in an employer-sponsored retirement plan is around $100,000, which is significant. If we flip to the next page, so we know that ERISA has helped employers put together a prudent process in the retirement space. And really, the three pieces of legislation that you see here are allowing ERISA to help plan sponsors put the big F into the fiduciary process on their healthcare plans. The first piece of legislation that came to fruition was January 1st of 2021, and it was the hospital pricing transparency. This required hospitals to provide patients with information around the cost of their procedure prior to them actually having the procedure and giving them the benefit of being able to shop that procedure around to other hospitals. While we know most hospitals are not compliant with this regulation yet, the data is available, and that's a good thing. The Consolidated Appropriations Act, which is what we're going to spend a lot of time on today, came to fruition January 1st of 2021. And what it really did was allow employers to now take control of their costs by adding transparency to what we considered a black box, which was the healthcare industry. And we're going to talk a little bit about that today. And last but not least is the transparency and coverage, which is providing employees and individuals with the ability to understand what costs for care look like and be able to shop for high quality, low cost facilities. It's promoting consumerism, but consumerism alone, or should I say the tools alone that you're going to have to provide your employees with, are not necessarily going to change behavior. Employers are going to start to align incentives, which is going to produce better consumerism of healthcare and ultimately control costs for them and enhance the benefits for their employees. So we're excited to talk today about the Consolidated Appropriations Act. And I'm going to turn it over to Karen to kick us off with what that looks like.
Well, I think that the CAA really does provide a great opportunity for employers and for their employees, because healthcare is probably the second largest budget item for an employer. And of course, your employees are that's where they get their healthcare. So by really figuring out how your plan is administered and making it more effective, you're going to save yourself money, you're going to save your employees money, and you're going to be able to retain a better workforce. So basically, the CAA removes barriers that were in place before for employers to really understand what's going on with their healthcare. And it does so in 4 major areas. It does so by removing gag clauses from service provider contracts. It requires disclosure of direct and indirect compensation from all service providers, just like the 408(b)(2) regulations did with the pension plan space. It establishes reporting requirements for pharmacy and prescription drug disclosures, and it requires parity in substance abuse and mental health benefits. And, there's great rewards, as we said, but there are also potential risk, and that is that the government may look at you for noncompliance, and you may be the subject of class action litigation because suddenly employer-sponsored healthcare is kind of in the spotlight. Next slide. The first really important thing, I think, is the prohibition on gag clauses. And what we had seen in the market up until now was that pretty much if you hired a TPA that was a big insurer to get network access and to administer your plan, you had all kinds of provisions in those agreements that limited the data that you could get from the TPA. So you really didn't know how your money was being spent, and you really didn't know what the benefits were that you were getting. So what the CAA does is it says that you must remove all gag clauses from contracts that limit your access to data. And what does that do? It will show you what the costs are. It will allow you to decide whether you're spending your money efficiently. It will provide enrollees, your participants, your employees with access to information so that they can make informed, cost-effective healthcare decisions. And it will allow employers, plan sponsors to identify waste and to identify ways in which they can improve their plan through comparative analytics. So it really does open up the black box and give you a lot of information that's necessary for you to do your fiduciary due diligence and to make wise employer plan sponsor decisions. Next slide.
So when Karen started talking about gag clauses, the first thing that always comes to my mind is, what the heck is a gag clause? So as a consultant that's been helping plan sponsors through this fiduciary process, here are some common gag clauses that we've seen among contracts. Information that limits you from benchmarking, information that limits you from developing any type of pricing transparency tools, any information that's any of your data that you can't use for RFPs or RFIs, anything that prohibits you from steering members to the appropriate providers. These are all considered gag clauses, and moving forward are prohibited language. The benefit of removing these can be substantial. If we flip to the next slide.
Yeah, so thanks, Jamie, Karen. I at the end of the day, what is the real application that the government is trying to get plan sponsors to, working with people like Mahoney Group and working with Jamie? It's really to do that type of analysis. When I listen to Karen and I listen to Jamie talk about gag clauses, it's almost a gag clause is really prohibiting you as a plan sponsor / fiduciary from proper procurement of your benefits to work in the best interest of your participants. So just so you know, I'm just going to show you a practical application where a gag order typically does apply, and it goes to Jamie's comments around benchmarking. So through your data, and that's kind of where it all starts. If you're a self-insured employer, this is your data. You are paying the claims. In the data using technology, you can actually look at, for the same exact procedure code, what do the different providers charge? Then you can go down to the actual facilities, as this graphic would show you. This actually real facilities, real provider data, just de-identified to be appropriate here. But I call this Sesame Street procurement, right? You put all the data out there, you look at the different facilities for the same exact procedure, and you would see in this data that facility C and facility H should be examined further. Somebody like the Mahoney Group would actually then combine this with quality data to ask, is there any reason you're actually paying that premium for an expensive facility? Does it create better outcomes? Very much in parallel with what you've done on your retirement plans since 2006. If we go to the next slide, and this is really where I look at this legislation, and this doesn't come out of my mouth a lot. This legislation really was brilliant. And what you get into is, to some degree, the government understanding that the industry would be very resistant to remove those gag clauses. And just to be clear, the industry over the last 2 years has been very resistant to remove the gag clauses. Jason could tell you, I'm sure, stories about how complicated those conversations get. So through hospital payer transparency, as Jamie covered early on, the hospitals now have to list 300 of these procedure codes and what would be the cash price for those at this, and that was effective 1/1. Now, and the government has started to levy some serious fines to get the hospital participation up from about 40% just 6 months ago up to 84% participation today. And then you have the payer rates, which I don't even like the language of that, but that's what the law says, because you actually, as the employer, are the payer. But the people adjudicating claims, whether that's a TPA or carrier, now have 500 procedure codes that they have to give those rates publicly. The other huge data set that we can now incorporate into data is the Medicare paid rates that have been out in the industry for a while. So this is very much a breakthrough, the hospital payer transparency. And if we go to the next slide, I'll show you why. Because now through technology, you can really get around the gag orders that the industry is very resistant to take off, because in one data set, you can have, for the same procedure code at the same exact facility, you're able to see what your plan is actually paying. You're actually able to see what the cash amount would be at the provider. And then you are actually able to see the public rate data from the given carriers and TPAs, so that you can really do fiduciary procurement in healthcare for the first time. I will tell you that these data sets, the public rate data, I believe is going to turn out to be inaccurate, just like it was in retirement in 2006. But by working with people like Mahoney Group through fiduciary procurement, with Jamie, and at times involving ERISA counsel, these data sets will get better due to having really uncomfortable conversations with the hospitals and payers that will make them need to get their data sets more accurate. And that's the way progress in these fields occurred in retirement. And I already see it shaking out the same exact way in healthcare. So without further ado, there are questions. Obviously, you can run those through the Q&A and we'll handle them at the end. But I'd like to turn it back over to Karen, because we are now going to get into full disclosure of your service provider's compensation to really get at where there are conflicts potentially with people providing you services.
Yeah, so then the second major thing that the CAA did is required disclosure of direct and indirect compensation for all service providers, which Jamie is going to talk about. So next slide.
Sorry. Yeah.
So sorry, if you flip it to the next slide. All right, great. So listen, everybody deserves to get compensated for hard work, and healthcare plans are not easy. But the reality is that employers need to understand what they're paying, who they're paying, and the services that they're receiving. So similar to the 408B2 regs, this is the 408B2 regs for the healthcare industry, where your service providers, anybody that's expected to receive over $1,000 or more in compensation, needs to provide you with a disclosure notice that provides you with direct and indirect compensation. Now, if we flip to the next page, what we're finding is that many employers may have received compensation disclosure information. However, 99% of it has not been compliant. So the first piece of information that the service provider must provide you is their fiduciary status. So what we're finding, and this is actual language that you're seeing in the disclosure requirements, is that the majority of people are not acting in a fiduciary capacity. So this type of language is perfectly acceptable. If we flip to the next slide, the second thing that I said that you need to receive is the direct compensation. Direct compensation is traditionally compensation that you as a plan sponsor are aware of. This might be listed on your 5500 form. Indirect compensation also needs to be provided to you. And that indirect compensation has to have services attached to it, just like the direct compensation does. So in the service provider's disclosure, it must have direct and indirect compensation listed with the services that you're receiving for that compensation. Now notice what we're seeing in most disclosures are the consultant or broker or provider saying upon request or on request, we will disclose this information. This is not compliant with the CAA. You as a plan sponsor need to have access to direct and indirect compensation, and you need to understand the services you're receiving. And then you need to deem those services reasonable under ERISA. Otherwise, you're considered having a prohibited transaction. Now, keep in mind, the regulations don't say you need to go with the cheapest, but you do need to understand who you're paying and what you're paying for. If we flip to the next slide, the other last piece that you'll want to understand about your disclosure requirements, or the language you may say, flipping to the next slide, is there's a pay to play where your covered service provider may have a preferred panel of partners. Now, this is totally acceptable. As a plan sponsor, you need to understand what those are and who they're benefiting. Are they benefiting you and your employees, or are they benefiting the vendor? And again, this is something that we're seeing a lot of language in the disclosure requirements that are saying that they do have and do place business with preferred panelists. And again, not anything that they can't do, but just understanding the cost associated with that. So these are some common things we're seeing. Again, we have not, with the exception actually of Jason's group, we haven't really seen any that are truly compliant with the CAA. So with that, I'm going to turn it back over to Karen.
Okay, so the next area that the CAA dealt with is to establish reporting requirements for pharmacy and prescription drug disclosures. So I will explain those if you'll flip to the next slide. Basically, the CAA requires plan sponsors to report certain information to Health and Human Services, DOL, and the Treasury. And this includes different categories. I'd say those first three categories are really about the plan, how many participants, the beginning and the end of the plan year, and the state. Then the next three really go to what your prescription drug look like in terms of what you're providing to your participants. It includes the 50 brand prescription drugs most frequently dispensed, the 50 most costly prescription drugs by annual spend, and the 50 prescription drugs with the greatest increase in plan expenditures. So this is going to give you useful information when you find that out. Then it goes to information about the total spending on healthcare services and the average monthly premiums paid by employers and employees. And the last two, I think, are really the important areas, because the real black box in healthcare have been rebates, and particularly when it comes to PBMs. And what 9 and 10 do is require you to report the impact on premiums of rebates, coupons, other similar remuneration paid by drug manufacturers to the plant. So it's all these other things that come in. And then any reduction in premiums and out-of-pocket costs associated with rebates, fees, and other remuneration described in 9. So now you'll be able to see the impact of rebates on what you're paying and how they affect your plan and your participants. The Department of Labor and Health and Human Services and Treasury are supposed to gather this and analyze it. And they're going to publish an analysis in a format that will enable plans to be, they think, to negotiate fairer rates and ultimately lower the cost. So this is partly disclosure to give tools to the government to help control the cost of prescription drugs, but it also provides plan sponsors and fiduciaries with really important information about a huge component of their medical plans, and that is the prescription drug benefits that are provided. So let's go to the next slide.
Yeah, so as you look at the really practical application of this, and it's just to continue off of Karen's thoughts, working with a really large employer we work with, it's very interesting how the industry is reacting to this. Pretty much that employer had a week to decide, 7 days, to whether they would have their PBM deliver that electronic file to the government and waive their right to see any of the data, or would they not have the PBM do the data at all? That was the choice. That client, working with ERISA counsel, decided to not sign on to have the data go to the government without them being able to see it. And that is a little bit of the dilemma. Even if you do the reporting requirement to the government, it doesn't mean as a fiduciary, you've actually examined whether the prescription drug program is working correctly, and from a procurement standpoint, working for you as an employer plan sponsor. But more importantly, does it work for the participant? Or are you actually positioning yourself for potentially a class action lawsuit? So let me just kind of go through the practical application that we see in the data every day. So when Karen went through the 10 components required, I would say out of most of the PBMs we do business with, and we have well over 4 million participants in our data set, we get the first 8 elements in some fashion to assist clients with. The last 2, which are about rebates and other remuneration, we do not really get that data from any PBM in America today. We are working with some PBMs to do this for year end. But why does the government care? It's very similar to the group annuity fees, 12B1 fees that were riddled throughout insurance contracts and mutual funds in 2006. The Department of Labor really cares of whether something an employee paid that gets reimbursed, does it ever get back to that participant? So just looking at one drug example, here you have a $294 drug. A lot of the railing is around the manufacturing cost. You'll see in this example that manufacturing cost, let's just call it 60% of the cost of the drug. The wholesaler of that drug to a pharmacy, that's another $21. And the PBM has $103 that comes out of this specific drug. And the question is, how much of that $103 ever goes back to the plan or the participant? And that's where ultimately the government is trying to get their hands around this. But every single self-insured employer in America wants to understand this issue as well. And then on the right-hand side, I just give you the implication with 2 different plan designs. So on the upper right-hand side, you see that in that case, regardless of how rebates work, they really affect the plan and reducing the plan cost, because the participant's copay is going to be $40 whether the rebate happens or not. But for those that are in a high deductible plan, just showing you one level of risk, if this is in the first 3 months of the year and you had a $5,000 high deductible plan, 100% of the cost of that first $5,000 would hit that employee. So there is a rebate to be had, and it goes back to the plan or doesn't go back to the plan nor the participant. Now that participant potentially, or a class of those participants, would have the same type of claim that we saw come out of the retirement industry going into 2010. So this is just real clear in the data that this is an issue. You want to get the data, you want to work with a competent advisor consultant to examine exactly how your procurement is going on and whether that's consistent with what's in the best interest of your participant. And by it being done wrong, could it potentially bring liability back to you as the plan sponsor and ultimately the employer in given cases? So hopefully that's clear. Definitely in Q&A, chat, ask questions, and we'll hit those at the end. And hopefully I got it right this time. I'm going to flip it back over to Karen to cover what's going on in parity and mental health and substance abuse.
Yes, so the last thing is that the CAA did is dealt with mental health parity. And let's here, mental health parity has been in existence for a while. But what it really did is require mental health parity with respect to quantitative treatment limitations. And that would be like copayment requirements, numerical things that you couldn't put rules in place for mental health parity and substance abuse that you didn't have for medical care. What the CAA did was focus, there's a big focus in Congress right now, a nonpartisan real focus on mental health parity. And it's partly because of the opioid crisis and partly because of the suicide rates and everything else that's going on in this country. So what the CAA did is it also required you to look at non-quantitative treatment limitations. For example, that refers to network admission criteria, medical management programs, coverage policies. The Department of Labor just settled a case with United Healthcare in which it dealt with limitations on what they were paying and also requirements that they put in place before you could get mental health care. So that's the type of thing they're looking at. There is a lot that the DOL is doing right now because it's been given a lot of money and a lot of responsibility to really enforce these provisions. And unfortunately, in their last report to Congress, they pointed out that there basically wasn't any compliance with mental health parity. It's kind of shocking. And what was happening is employers all believed their TPAs were taking care of it, and the TPAs weren't taking care of it. And so the problem is that you as an employer have the responsibility to make sure your plan is in compliance with mental health parity laws. And currently, plan sponsors have to attest to parity with the quantitative limitations. And going forward, they must attest to non-quantitative limitations. And I see somebody ask what TPA stands for. That's a third-party administrator. It's the entity that administers the plan on behalf of an employer. So I think that with respect to what employers need to do, they need to ensure that the plan has a vendor that will provide this comparative analysis and be prepared to respond to a request for documentation. So next slide. The DOL has published a tool which lays out a series of questions across the context of what a fiduciary needs to look at. And parity, there's a question from the audience about what does parity mean? Parity, it's a little bit difficult because as you can imagine, you can't always compare medical care treatment to substance abuse or mental health treatment. So that's what the Department of Labor is trying to do with this tool. Is it kind of goes through 8 different things that you have to look at, questions you have to answer that help you figure out whether in fact you are complying with mental health parity rules. And you can see the list right now. I think that it's complicated. And I think that employers really need to pay attention to it because the Department of Labor is certainly paying attention to it. And they have to, I believe, make reports to who isn't in compliance. They have goals that Congress has set for them in terms of making sure that employers are complying with the mental health parity laws. But there is a link here to the DOL tool. And having worked for the Department of Labor for years, I know that they're serious about this. But they want you to come into compliance. That's their #1 goal. So if you have questions about it, talk to the Department of Labor and they should be able to help you make sure that you're complying with this really important rule. Next slide. So what you see in the retirement space has been that there are big settlements. I remember back in 2007, I think it was that the Schlichter law firm filed the first 401k fee case, and it was came as a shock to the retirement community, which really hadn't been paying attention to their 401k plans. And suddenly they had to start paying attention because there was lawsuit after lawsuit. And as you see 2 examples right here, where BlackRock was required to pay $9.7 million to its own retirement plan for failing to follow the rules, and a $40 million settlement that the Schlichter law firm got. So this is big money, and it all, what it ended up doing is it really transformed the 401k industry, as Jamie pointed out. And you have this great potential now for the healthcare industry to be transformed because all of a sudden people are going to be looking at what's happening. And we see the Osceola schools sued because they said their consultant was greedy in the choice that they made in terms of who was advising them. And I think that what's going to happen is that the more employers start looking at fee disclosures and at the information that gets revealed after gag clauses are removed, you're going to be shocked at how much waste there is, really what's really happening in the healthcare space. And you as an employer are then going to have to take action to fix it, because if you don't, bad things are going to happen. So now we'll go to the next slide. And this is what ERISA attorneys are saying. Number one, that it's going to have a huge impact on health plans. I really think it will. I think it will also transform the industry, because I think that there are all kinds of innovators out there that are coming up with new solutions as to how you can administer your plan in a way that more fits your employee population, that really saves money for you and your participants. And I think that the real risk you have is that your vendor lulls you into complacency. Julie Selesnik, my colleague at Berger Montague, said this is a quote from her, and I think that this is very true, that what you see is a lot of employers want to keep burying their heads in the sand and think, well, my vendor is taking care of it. My TPA is taking care of it. And we've heard all kinds of situations where the vendors are saying, well, we'll do your attestations and prepare them for you. Well, you're doing an attestation that you've removed the gag clauses because you have personally looked at your contract and decided where those gag clauses are and have sought to remove them. And that's going to be a difficult task because the TPAs are going to resist it. But you cannot rely upon your vendor, because your vendor is not your friend here. Your vendor is who you're supposed to be monitoring on a regular basis to make sure that you're complying with your fiduciary duties and that you're that what you're paying is a reasonable cost. Because if it isn't, you're engaged in a prohibited transaction and you're in trouble if you get sued by the Department of Labor in class action litigation. So next slide.
This slide is very telling of how everybody must feel right now. It's kind of like drinking from a fire hose. But congratulations, because you guys have actually taken the first step and to start to educate yourself. I have 2 boys at home and they have summer reading that they have to do this year. And of course they hem and haw and say, my God, I don't want to do this, Mom. And I said, the first step you need to take is to open the book. So in essence, you have opened the book, everybody. And that's fantastic. So let's kind of try to take this in small bite pieces, because you are going to have vendors that are going to help you fulfill these obligations. But the first thing is, if we flip to the next slide, you need to acknowledge that you're a fiduciary. That's so important. No longer can you sit behind this, on the sidelines and say, I don't know anything. You now do know that you are a fiduciary on this plan, and ERISA has put the big F back into healthcare plans. By just acknowledging that, you then can start to establish a process and establish a committee. So very similar to what you do on your retirement plan. You have an investment committee that gets together periodically and reviews the information to ensure that what you're doing is in the best interest of your participants. The second thing that you'll want to do once you've established that committee is start to gather and review your contracts. Determine who are the partners that are acting in your best interest, who might be the partners that you might need to replace or want to do an RFP or RFI to just ensure that what you have in place is the best for your employees. There's going to be a lot of benchmarking that you're going to do. And that's an important piece of the process to determine if what you're doing is in the best interest of the participants. In reviewing those contracts, you're going to start to gather all of this data. And you'll want to put this into a warehouse, a data warehouse, so that you have this information readily available if you're ever asked for it. So you've established the process by establishing a committee. You've started to gather the documentation and put it into a single spot, reviewing those contracts. And now you need to start to prepare to report. So very similar to what you do on your retirement plan. You establish a prudent process, you adhere to that process, and you document that process. And I think Karen said it best, is that while the partners and vendors that you have in place right now are fulfilling certain services, they are not a fiduciary. So when you start to ask the questions, don't allow them to say, we've got you covered, because I guarantee you that none of you know what we've got you covered means, but it makes you feel good. And unfortunately, that is not a prudent process. So as Hugh and I like to say, trust the vendors you're working with, have an outside kind of fiduciary eye to verify and document and kind of store that information so that you really, you're really able to prove your process out. And we know that in the retirement space, it has had a significant impact on cost containment and efficiencies for employers. And we know that applying that fiduciary process with the right partners, you'll have the same outcomes in your healthcare plan. So with that, I'm going to turn it back over to Jason, and I think go into Q&A.
Great. Thank you, Jamie. I think we have quite a few questions that have come in thus far, so I'll turn that over to Elizabeth. And Elizabeth, if you could repeat those questions for our panelists.
Yeah, absolutely. So the first question that comes in is in regards to tribes. Is the CAA legislation applicable to tribes?
Karen, do you want to take that one from a legal perspective?
I'm not quite sure. I mean, I think that there's a whole question as to whether tribal plans are ERISA covered plans. I think that if a tribe employs people that are not members of the tribe, it is an ERISA covered plan, and therefore you have to comply with the CAA. I'm kind of an ERISA nerd, so I don't really know how it applies to plans that are not covered by ERISA, but it's pretty extensive. So,
yeah, if I could just kind of jump in there, I actually during the meeting was going to call a friend and try to figure that out, and it really came up with pretty much what Karen just said, and obviously she's incredibly qualified for that perspective. We can dig harder, and it probably is down to facts and circumstances, as Karen said. Maybe to just round out, to public entities, they're covered under PHSA instead of CAA. I mean, instead of the ERISA, and the only component that doesn't apply to them is the indirect direct comp disclosure, which is sort of ironic because the first lawsuit on that came from a public entity looking at indirect direct comp. Kind of leads me to my last part of that, is whether this applies to you or not, and we'll definitely work with Jason to do more research there. This is just the right way to approach your healthcare plan, because you will get incredible OpEx savings by using the process, the analytics, the benchmarking tools. The government is really inspiring you to just do the right thing, and they're releasing data to you that historically you've really been kept in the dark on. So I just encourage you. Obviously, meeting the requirements of law is critical. I would just tell you, whether it applies fully or not, there's huge operational savings and improvements in population health by using these guardrails to run your healthcare plan.
Great. The next question that came in, are any of the gag clause details specific to only fully insured versus self-insured plans?
So I would just remind everybody that the Consolidated Appropriations Act, regardless of your size plan, if you're an ERISA-based plan, whether you're fully insured or self-insured, does apply to you. Now, gag clauses in fully insured, and Karen or Hugh could step in keep me honest here. Fully insured environment traditionally doesn't have access to their data for the most part. And therefore, there are no gag clauses because you don't have access to your data. But it is the self-insured environment that you're going to find that the contracts, whether it's with the carrier, the TPA, the broker, may exist.
Yeah, I would just add that's like, I totally agree, Jamie. That's specific to the gag clauses. Indirect, direct comp requirements absolutely apply to both self-insured and fully insured. And you know, parity, that's how United Healthcare got caught up in the parity. They were responsible for that on fully insured. So, and where you can't get data, I always say this, it actually means you have to work with your consultant to do more benchmarking and probably more RFPs to still ensure as a fiduciary you're working in the best interest of the participant where your access to data is less.
And I would just add, Hugh, since you had brought up the direct and indirect compensation, the question had come in once before about, well, I'm in a fully insured environment and all of the consultants in my state make the same amount on that product. And so how do I deem it reasonable? And the reality is if you have a consultant that sends you a renewal slip and that's the extent of their services to you, and you have a consultant that comes out for the annual renewal and does education and is there to ask questions, and they're both getting paid the same, one you can definitely say is totally unreasonable. That one is the one that just sends you the renewal, and the other would be considered reasonable. So.
Yeah, and I would point out that another goal of the disclosure rules and the gag clause prohibitions is for plans to be able to see where there's self-dealing or there's conflicts of interest. And that's another thing that you should look at in terms of how your brokers or how other people in your plan are being compensated, because that could impact how they advise you.
How would the plan sponsor recapture the rebate amounts for the benefit of the plan?
If I could jump in quick on this one, I saw that. I would say the first part, and everybody tends to do this, we try to jump to the conclusion. I'd say the first part is to actually know what the rebates are at a drug level, right? Then there are, and this is the beauty around healthcare, there are a lot of very innovative solutions once you actually know the facts. And you might even deem some of the non-recapture of rebates is fine. So I would just say, really the first hurdle is, will the people that you're working with actually give you the data so that you could start to come to a reasonable conclusion on whether that is another form of compensation, and then be able to do an apples to apples comparison of the alternatives the plan and through the plan your participants have. So I just would really encourage everybody not to skip that step, because right now the biggest hurdle for a plan sponsor is really non-cooperation from their PBMs in giving them the data that's required by law.
Yeah.
Anyway, with that, I'll let other people jump in, but I just don't want you to think it's readily available, because it's not.
Right. I heard a situation where a PBM offered to pay the plan money to administer its drug program. And obviously it's getting paid with the rebates. So, you know, I would say as an employer, you'd say, wow, that's a great deal. But I would want to know how much the rebates were paying, because you should be able to figure out whether that's really worth it. You might do better with the rebates.
Yeah, and somebody caught us again using a bunch of industry jargon that nobody knows what it means. So PBM stands for Pharmacy Benefit Manager. Those could be separate entities from the person that adjudicates your claim in medical, or it actually could be the same entity. Sorry for, we use all this jargon and don't realize normal people have no idea what we're talking about.
Would you discuss how a small, mid-sized employer would use this data? What would a controller who has no background in healthcare do with CAA?
Jason, do you want to handle that one since you do that every day?
Yeah, I think it's just getting the basics and starting to understand how the plan functions first, and just getting get your feet underneath you. I think it's a good start. And then once you begin to understand the function of your plan and the structure of your plan, begin to then start walking into the components of CAA and the prudent process associated with CAA. But it's at first understanding the structure.
Yeah. And out of that
Understand the data,
structure,
right?
yeah, out of that structure and process, we do this with Jason's firm every day. There will be low-hanging fruit of opportunity. That's an entirely different session, but working with somebody like Jason and Jamie, you'll actually see out of the process operational savings for you and your participants, whether that's a different way to get injectable drugs, or it's a different way to assist your diabetics to be adherent. There's all sorts of gold in your data. And that's why you need to work through process, analytics, benchmarking, RFPing, work with your incumbent carrier and third-party administrator. They have programs that you're probably not deploying today or not measuring whether they're working. And it really is very similar to the process we went through that cut 5/6 of the expense ratio for your 401k, 403b, 457 plan. And the same rich opportunity is sitting right in front of us due to these multiple layers of legislation that are truly a bounce pass for the plan sponsor and participant. They just come with a little bit of teeth if you don't take advantage of them.
Yeah, and I would point out, I've been doing ERISA litigation for years, and the real trick is to put a process in place and to get experts when you need them. And I think that the case law is replete with examples of where people who didn't pay any attention because they didn't think they're an expert in the field, it came back to bite them. But if you're not an expert in the field, ERISA doesn't require you to get really even the right result. It requires you to put a prudent process in place to get the right result. It really judges you by the process, not by the result. But of course, if so there's a lot of people out there to help you, and you just need to take that first step to take it seriously.
It is truly a rinse and repeat of the retirement space. The same process you have in place in your retirement plan, you put onto your healthcare plan, and you want to have the same advocate sitting on the same side of the table as you.
Jamie, a question just came in specifically for you. Does your organization help conduct RFPs for brokers?
We do. That's part of the process. We can provide benchmarking for fees and services of your vendors, as well as, if needed, an RFP or RFI.
Great. What about public sector plans?
Yeah, so public sector, we do a bunch in the public sector. Same exact adherence to CAA, can take advantage of hospital payer transparency. Like I said a little bit earlier, the only area, for whatever reason, they get relief on is the indirect direct comp disclosure. But I would tell you, it wouldn't be a prudent fiduciary process to not actually get the direct indirect comp disclosure. So I would just say that stick to the program and you'll be fine, regardless of whether that one provision is required or not.
Yeah, and let me, I think I know the answer to that question, and that is because the ERISA has prohibited transaction provisions, which in order to get an exemption from them, you have to have the disclosures. But those disclosures are really designed to give you the information you need in order to be a prudent and loyal fiduciary. And regardless of what type of plan you have, those requirements of prudence and loyalty apply to you. So that's the reason you should get those disclosures.
And I think Karen, Julie had said to us once that sometimes there's a state law, depending on what the public entity is. There is a state law that may require that you spend the taxpayers' money in a prudent manner, and therefore you'll need to receive those disclosures to determine if that it's prudent or not.
Yeah, I often say a lot of these new provisions, there's nothing new in ERISA. ERISA's covered healthcare plans since it was passed. And when I first started doing ERISA litigation, it was against on healthcare plans and their service providers. It's just that the world has changed a lot and there's new systems in place. And now we have new rules to get the information. So the responsibility was always there. The tools are just there now.
Good. I think we have 2 minutes left. I think there's a ton of awesome questions in here. So I'm assuming after the meeting, we'll work together to make sure we get those answers out to everybody. But Jason, I'll leave it to you to wrap up. Oh, you're on mute, I think, Jason.
Again, thank you everyone for attending. To Hugh's point, we'll definitely follow up with the questions. We have several more. We have quite a few questions in the chat and then also in the Q&A that still remain. So we'll definitely forward those answers off as well. And we will be sending a recording of this webinar going forward to all of our participants here today as well. So again, thank you. Again, thank you to our presenters, Jamie, Hugh, Karen, thank you very much. And we look forward to hearing from you all again soon.
Thank you, Jason.
Thank you.
Thanks. Bye-bye.
Bye.